First, thank you, Robert, for joining today. Just give us an introduction of who you are, your background, and the product you'll be talking about today.
Great. Thanks for having me, Kallie and Christina. My name is Robert. I'm the general manager for RedDress USA. We have an autologous blood-derived product. I've been in the med device space for 15 years now, ranging from trauma ICU, urogynecology, and now wound care. So excited to be here and talk about the lovely world of wound care.
Awesome. Well, thanks, Robert. We're super excited to learn more about RedDress. Kallie and I were talking in SAWC spring. There was 2 PRP products, and then SAW fall there was 4. And so we just see, especially with all the changes happening in the industry with CTVs, that PRPs is kind of the next big thing. And we wanted to, as it's still manageable with 4 companies, really learn the differences of each of your companies. And I think RedDress especially, you're so different than your other PRP companies. And so just learning more about that. Where do you see PRP going? Do you think it is the next big thing? Where do you see the future?
Yeah. I mean, it's funny that you say it's like the next big thing because PRP has been around for such a long time.
I know.
Right. And I think, people have used it for years and had, great results with it. Now that kind of the space is changing with the coverage, the coding and coverage between, the blood-derived products category and CTPs, it's starting to become, I think, more popular in the classic kind of wound care channel. We have spent a lot of our time generating clinical evidence around the classic DFU, VLU arena and wound care. And for us personally, I can't speak for the rest of the companies in the space. Outside of the classic wound care space, we're focusing a lot on doing research in other kind of surgical arenas. The product has both. We could do both in a patch and a flowable format. And we find that flowable format is really a solution that, when there's those tunnels undermining fistulas, tracking, gives you a great solution on how to attack those wounds. And that drives some of the clinical research in that area. So I think we'll see a shift really cementing itself in wound care and then starting to shift to that surgical side as we go forward in the next few years.
Okay, awesome. And with all of the different products and yours being so different, can you talk about how yours is different than the other companies and maybe the process, the product packaging, how is it stored, all of those things?
Yep. Yeah. So Actigraph is a point of care kit. So it's just a little box. It has everything you need in it to do the procedure, ranging from the blood draw components to the procedure itself, the secondary dressings. And so the story I like to tell folks, it truly is point of care. I had somebody in Indian Health once call because they were going to the patient in the reservation desert area. They were not able to come into the office, and they just took the kit and went. As long as they had the blood draw capabilities, they were doing that in the field. So I'd say, first of all, this is truly a point of care solution that folks can stock and use in their facilities. It is quite different from some of the other products in the space. We don't have a centrifuge, and there's a clinical reason behind that. The summary I'll give is, if you think about a blood clot, that's actually the body's natural skin substitute. When blood clots, it creates a fibrin matrix, and whole blood retains all the cells that are naturally required to go through the healing cascade. So all we're doing is basically tricking the body, thinking a chronic wound is an acute wound, starting back at that hemostasis phase, and then starting to work through that process again as we give it the ammunition to continue the healing process. So there is a very significant clinical reason around why we don't have a centrifuge. But the process itself is pretty straightforward. We draw the blood. That takes a few minutes to do. Then we actually coagulate the patch, which takes about 5 minutes, and that's inclusive of patients on blood thinners. So it ends up being something very quick. And the nursing staff can all do all the prep work to get the patch ready. And once the patch is ready, you have an hour to do the application. So typically the physician will come in, do their debridements, application, and move on. The good news also is that this is all ambient temperature storage. There's no refrigeration in addition to the centrifuge lack of centrifuge. So it truly ends up being a pretty easy and straightforward process to manage and deploy in a clinic.
Awesome. And how long would you say your process is from start to finish?
Yeah, it would take, we do it normally in a typical clinic window. So normally you're booking somewhere 20, 30 minutes for an appointment, and the whole appointment gets done in that that window. The blood clot itself, in terms of actually forming, it takes about 5.
Okay. Okay, great. In talking about processes, the feedback we got, because we are doing PRP, I'm just kind of trialing it in a few of our centers, and the biggest hurdle is the blood draw. It's one, a lot of us wound care nurses haven't had to pull blood in a long time. And so we're just not as confident. And then the second is these patients that we're dealing with is an older population. So they're
Yep.
hard sticks.
Yep.
Do you feel that those are the same hurdles you're hearing with your clinics? How are you kind of getting through that? And does your product, because it is slightly different than the other PRPs, do you have any other hurdles we're unaware of?
Yeah. I mean, so starting with the blood draw, it is a blood product, right? I think for the category, they haven't invented needleless blood draw yet. So when they do, we'll be very interested.
Let us know. Let us know when that happens, Robert.
Exactly. So, I think that there are a couple tips and tricks that you can do. First is always coach the patient to hydrate, right? And coffee is not hydration. So, water. A lot of times when folks show up to the clinic, they'll just give them a cup of water while they're in the waiting room before they come back to the procedure room, just to make sure that one last step of let's give ourselves the best chance to do this. Most of the time when it comes to the clinics, we find that I would say 60, 70% of the staff are kind of like yourself, where I used to do phlebotomy or blood draws, right? It's like riding a bike. I just kind of have to, do a few sticks to kind of get back on the bike again and start pedaling. And so once we get through those first few, generally that helps them a lot to build their confidence and continue going. One thing that is unique for us is that you could decouple the blood draw from the procedure itself. So what we'll see a lot of clinics do is, while the patient's in the waiting room, draw the blood, label it, put it back in the kit. And so that way there isn't this, you have more flexibility in terms of the blood draw process itself. And they'll also set up like a clinic day where it's the actigraph day. So on Wednesdays at, 10 a.m., we're going to start this and we're just going to do the rest of the day for patients. So you kind of get into that routine then of doing that process. And then the other thing I would say that is helpful, we find that there's these vein lights that illuminate and help stabilize the veins. So sometimes there's tools that you can use to kind of help for those difficult patients.
Speaking on patients, what are you guys seeing in terms of patient compliance, and how often are they able to get into the clinic to receive this treatment? And how often are those visits?
I think the standard is, once a week. I think in, some instances you could get them, multiple times a week if that patient is super compliant and engaged in their journey. I will say that we find that there's always this interesting conversation that happens with the patient and the clinician now is, hey, listen, patient, I'm going to use Kallie as an example. Hey, Kallie, I'm here to help you on your healing journey, but you're actually going to heal yourself because I'm going to draw your blood and we're going to create a patch and we're going to use your body's own mechanism to heal itself. So there ends up being this kind of transmission of almost responsibility and accountability on the healing process back to the patient, where you can have this interesting dialogue that starts the process. And generally from there, you'll go to a weekly application as you go forward. We do see that, if there's somebody that's going on vacation and let's say they can't come back on that Monday or Tuesday, see them on a Friday, that's fine. They can do that. And that works out pretty well.
Oh, thanks. Yeah, I like that, during that patient education, it does kind of put that ownership back onto the patient. Like, I'm doing this myself. You're just helping me, right?
Yeah.
So that's really great. So thank you for that. So another thing that Christina and I were discussing prior to these interviews, and we've kind of been trying to ask everyone to keep it, fair, that you guys are all getting the same questions. Talk to us about dressings. So primary, secondary dressings. Do you have any best recommendations or best practices? Because in our clinic, like we said, we're trialing these, and it's kind of like trial and error. This one works, this one doesn't. So we just kind of want to see, what's your take on that?
Yeah, every patient is different. Every wound is different, right? So it does, I think, take some clinical assessment to kind of figure out what the right dressing is. Our kit comes with a standard where we have a non-adherent pad, a 4x4 foam, and that's at least the baseline. But I think what you will find, at least with Actigraph, given its whole blood and you've got that extracellular matrix and you've got all those cells, it wakes the wound up. right? You basically go back into this inflammatory phase, macrophages go in, they start to chew stuff up, exudate goes up, right? So you really have to spend some time communicating and educating with the patient around if you get strike through in the secondary, that needs to be changed. Perhaps you can get them back into the clinic to do a mandatory change during the week. We do have a dressing guide that goes through, like, these are different scenarios around where you might think about using these types of dressings. And then these are the products in that category that you should think about. So, but definitely encourage clinicians to, counsel patients and watch the secondary for no, I mean, we're very excited to be working with you all. And I think that, maybe one last comment is what we've seen a lot of folks start to think about this category, right, as a useful tool in their bag. It's not the only tool they should have, but probably one of the many. We call them the lost patient groups. So it's, Medicare Advantage patients, typically those are difficult to find covered advanced therapies on. And with the national coverage determination in this category that offers basically universal coverage for Advantage plans, patients with exposed bone and tendon, those are areas where, again, there's not a lot of options. And so we'll see people really start to gravitate in this area for that. Irregular wounds or those tunnels and tracks, right, where you have that flowable option, that tends to be something where you don't have another solution on. And then finally, like religious patients. So there truly are a lot of folks out there that have beliefs that they don't want other third-party products on their body. And this category ends up being a solution for them, that can meet their religious requirement along with their healing goals. So I think we start to see people really think about using this in those categories first and get comfortable because they're solving a problem they have every day, helping the patient, which they need something to do. And then as they get comfortable, then they start to expand and think about how they approach their patient population thereafter.
Thank you. That was really great insight. I love that.
Yeah, for sure. Things that I guess not a lot of us have been thinking about, right?
Mhm.
Especially the religious aspect. Who's thinking about that and what are we doing for those patients? So I'm glad that there is this option for them.
I'm just excited to see the podcast, and if there's more topics you want to cover in the future, don't hesitate. Happy to participate.
Cool. Thanks, Robert.
Well, thank you.
Thanks,
Bye.
Thanks, Kallie.
Listen or watch full episodes on YouTube or Spotify.